And the purpose of the recording is so we can share it with the webinar. The purpose of this webinar is to spread awareness. So whatever we talk about, we're hoping that it reaches a larger audience. So I will start by sharing my screen. Please let me know if you can see it. Can you see it properly? Okay, awesome.
Yes, yes.
Right. So thank you all for joining us today. Today we will be talking about a very crucial topic that has been having a global impact, and also it has been topic of conversation a lot more in the recent decade in Bangladesh. So our webinar is called The Silent Crisis, and we will be discussing why it's beneficial to talk about men's mental health. So now I'll go ahead and talk about our panelists. So I'll start off by introducing myself. My name is Farzana Matin. I am graduating from Teachers College, Columbia University this May. I'm a healthcare research focal at YPF, and my interests are in being a mental health advocate and a clinician to address mental health disparities in under-resourced communities of color. And now I'll be talking a little bit about our panelists. So I'll start off by Dr. Marie Maville. Dr. Maville is a licensed psychologist with extensive expertise in multicultural counseling, gender roles, and identity development. Dr. Maville's scholarly interests encompass multicultural counseling, Latinx mental health issues, universal diverse orientation, social attitudes, and identity formation. She's also recognized for her contributions to clinical supervision guidelines in health service psychology as a member of the American Psychological Association Task Force. And on top of that, I had the pleasure of being in one of her classes this semester. So I'm very glad you could join us today, Professor. And now I'm pleased to introduce Dr. Tasdeeq Hassan. He is a PhD fellow in digital mental health at Monash University in Australia. In addition to his doctoral research, Dr. Hassan serves as a teaching fellow and an assistant lecturer within the Faculty of Information Technology at Monash University. Dr. Hassan is also the fellow in healthcare and well-being at the Youth Policy Forum, or YPF. And lastly, Dr. Lisanul Hassan, he is currently doing his post-graduation training in psychology. He's a medical officer who is also involved in insight, psychosocial care, and research. So it's a pleasure to have you all join us today. And now I'll be talking a little bit about what Youth Policy Forum is and what we have been doing. I'm sure some of you are familiar with the work, but I'll just go over to give a brief overview. So Youth Policy Forum is a platform of young Bangladeshi people from all over the world who have interest in nation building and state crafting and want to contribute through effective policy formulation and implementation. Some of the work that YPF focuses on is policy advocacy, which aims to reintroduce policy into politics by collaborating with national and international groups, ensuring a spillover of policy knowledge. And it also works to facilitate deep discussions on various policy areas, and that encourages research and knowledge exchange among members to strengthen their understanding of policy issues. And YPS also offers fellowships to exceptional Bangladeshi individuals who contribute to different parts of society. One of them is being mental health. So now I'll be talking a little bit more about how YPF has contributed to the dialogue that's going on in Bangladesh about mental health through various initiatives and programs, YPF aims to raise awareness, reduce stigma, and also improve access to mental health services in Bangladesh. Oops, sorry. And now I'll be giving a little bit of stat and like the research we have done in YPF on the mental health crisis of Bangladesh. So currently in Bangladesh, there are only around 500 psychologists and 270 psychiatrists to treat a large number of mental health patients. And from my personal research as well, I've seen that the World Health Organization have highlighted that these are mostly resources available in the cities, and there's a dire need within the rural communities. However, there's no resources available for a large number of people there. There's cultural aspect of it. One of the things we will be talking about today is men's mental health. And there are cultural stigma where men are often taught to repress emotions from a young age, leading to undiagnosed depression and other mental health challenges. People in Bangladesh suffer from a lack of well-established healthcare referral system. But in 2018, there was the Mental Health Act that was passed, which is a very big step for Bangladesh as it aims to protect the property rights of individuals with mental illness and provides provisions for mental health services. But even though this is a big step, there are substantial investments in mental health infrastructure and awareness campaigns that are needed to destigmatize mental health issues. And now I'll be passing it over to Dr. Mivil. These are some of the issues she'll be talking about.
Thank you, Farsana, and greetings, everyone. I'm honored to be invited today to talk about men's mental health in Bangladesh. So let me begin by just identifying myself and a little bit about my positionality regarding this important topic. So I've been a university professor for many years, engaged in research and scholarship about gender. I've oftentimes looked at gender in context with many other aspects of life experiences. For example, one's race and ethnicity, that is, in this case, being a man within a Bangladeshi cultures. And so that it's very important when we talk about gender that we not just talk about it as some nameless, faceless construct out in a vacuum, that it's very important to understand gender within a cultural context. I personally myself, I identify as Latina of Latin American heritage. I'm female. I was both born and raised in the United States, and that is where I primarily have lived. Though I do have half of my family, my Latin American part of my family is still mostly located in Colombia and South America. So I actually have a very strong if not a professional experience with international issues, more of a personal understanding of what immigration means and so on. Actually, if everybody could make sure to mute your mics, thank you. So let me also start by talking a bit about assumptions about gender. And so our understandings about gender let's just talk about psychology or in the mental health professions, have multiple sources. The notion of gender is not something invented by mental health professionals. It is something that has long been a part. Gender socialization, your understanding of who you are and what your role is in the larger society, has been a part of human cultures for millennia at this point. And we derive our understandings of gender from critical religious and spiritual beliefs that still impact many, if not most people around the world. Political and legal understandings also affect our understandings about gender, as well as scientific, which is where psychology and the mental health professions are nested. That's the context. So historically, gender has been viewed as biologically based. That is, biology is considered destiny, where we have binary notions of gender and very clear, and many cultures, even today, have fairly clear lanes for how women and men enact their roles in terms of masculinity and femininity. So values, norms, beliefs that have been around for many years focus how we think about gender legally as a type of public policy, and then also how we approach gender in scientific research, as well as mental health practice and interventions. Even the questions that we ask as mental health professionals belie long-held beliefs about gender. So over the past 200, 250 years, across many generations, women around the world have begun to understand gender from a perspective of a marginalized status. And so that there have been multiple movements around the world regarding advocacy to change more of that disparities that can exist between genders. And since the last century. And so we've seen that even including the actual existence of psychological research exploring gender as an impactful aspect of people's lives, as well as the availability of services that can actually effectively treat people who may be dealing with issues that arise from gender issues. So today, we now understand gender much more in psychological terms as something one does, enacts, performs, rather than some kind of rigid set of traits that we all inherit because of our biological destiny. We also now today emphasize the importance of context, the importance of structural impacts that may lead to disparities that exist, and even for people that we might consider in more privileged status. So when we think about men, boys and men in terms of gender, it's important to start thinking about what does masculinity mean? Because that is probably still the key gender construct that most boys and men are socialized with culturally, and then what we investigate in terms of scientific research. We also, some of the key traits that are important to understand about masculinity are things like independence, adventurousness, being aggressive, taking the step, being willing to take risks. And another very important aspect of masculinity that remains important for boys as they become men is this notion of proving oneself regarding your courage, your strength, the kind of skills that you bring to a situation, as well as the roles that boys are expected to learn to become as adult men. That is, being a husband, a father, a worker of some kind, a leader, a protector, a provider. So one of the things that's become important as we have evolved this construct of masculinity within mental health is to understand that there are nuances or multiple aspects that are important to understand about masculinity. Is not an either or understanding, and that there are actually certain themes of male role socialization. And could folks please mute their mics? Thank you. That there are certain themes of male role socialization that can lead to health impacts, including physical and mental effects. So it's not correct to talk about masculinity that's toxic per se, but simply that what are the aspects of masculinity that have already been found to be problematic in terms of their impacts on health, both for oneself and then the kinds of attitudes and behaviors you may engage with other people, including female spouses and so on, women in one's life. So one of the things that has been found, for example, the aspects of masculinity that can contribute to difficulties is this constant emphasis and focus on power and control, being controlling of others. And this has been found particularly to be important in terms of negative and dominative attitudes when it comes to girls and women. And so it's actually that nexus of relationships and engaging in kind of that super controlling behaviors that has been linked with some difficulties in terms of mental and physical health, both for oneself and then what you're doing with other people. So the role of gender roles in contributing to masculine health, to mental health regarding masculinity with men, is to think about how masculinity socialization specifically affects people. So around the 1980s, psychologists began to ask about the impact of gender on boys and men. Up to that point, there had been almost nothing about that. And so some really important constructs that have been found to be very important in understanding mental health and physical health are things like gender role strain, which is came up by a psychologist named Pleck, who, with that construct, acknowledges that even a privileged social role as a man can have its own psychological impact that can be, not necessarily is, but that can be potentially negative and harmful. And that, in fact, trying to live up to some of these masculine expectations, especially around the dominative pieces, can actually cause damage physically and psychologically and emotionally. Another important construct is gender role conflict, which happens when people have rigid, sexist, or restrictive gender roles to the point that, that a man may end up restricting, deviating, or even violating others or themselves. That those roles are so adhered to rigidly. And that's another key aspect that's been found to link gender with health impacts, is this kind of rigidity rather than flexibility. Flexibility is an attribute that's been found to be quite important in maintaining psychological health and strength. So when we think about the impact of gender role socialization and the impact on health, there's all kinds of health statistics, and I'm actually quite familiar with more US-based. But some of the things we have found that is unquestioning and rigid adherence to masculine beliefs and norms can actually lead to a lower life expectancy. Because, for example, you may not understand or even be able to acknowledge when you're not doing well in life. You know, if you think you have to always be strong, always be in the lead, where does that create the space as a man to say, I'm struggling with something, I need help? And so sometimes some of the ways that men over the years have come to just manage stress in their lives, you know, things like alcohol or substance use, which can then lead to abuse. And there's can be things like accidental deaths or engaging in very risky behaviors that probabilistically speaking can lead more men to die younger than what we might normally expect. And there's even something called a gender paradox in the literature that looks at suicide risks. And the notion, the gender paradox is that women tend to think and attempt more often about suicide. However, it is more men that often die of suicide, most likely because of the methods that, you know, driven by socialization tend to be just more likely to end in harm. Things like using a gun and so on, they have less likelihood of surviving that attempt. The other highly risky issue when it comes to looking at gender and their impact on men and their relationships with others is something called gender-based violence. We can see that in issues like intimate partner abuse, abusive children, and possibly other young people in their lives. Not just young girls, but we're finding more and more the risk of violence toward young boys is quite high, and almost matches that of girls for children 10 and under, at least we have found here in the United States. Other issues with gender is looking at stigmas and taboos associated with mental health. As I said earlier, as strong and independent men, it's hard. It can be hard to acknowledge first to oneself and then to other people, something's wrong and I need to have help. So some of the things to think about public messaging, some of the innovative things I've seen here is utilizing famous role models who now openly talk about their long-time work with therapists. I've seen people like music performance artists now. There's a famous basketball player who talked about the notion of man up and get the help you need. So there are ways now even of thinking about messaging that is congruent with how men may see themselves and couple the message of seeking help within that socialization, right? It's important to think about messaging that reaches the best people. There's also policies that you can think about to boost national mental health directed towards boys and men. Things like, and one of the things I can point to you as an excellent example is the American Psychological Association has developed what we call practice guidelines that gather together research and service implications regarding particular topics or populations. And so now there is a practice guideline geared towards boys and men that I would urge you to take a look at because it summarizes a lot of the most recent research and provides suggestions for things like intervention, for community advocacy, and even some kinds of policies. And that can be a good source just to even begin to get ideas for what you might want to do in Bangladesh. Other things you might think about as a professional is leveraging if there's a professional association in Bangladesh. I know here in the United States, we have the Asian American Psychological Association. That might be an organization you could partner with. I know people in that organization. It's a great place, great group of people. There's also APA has an international office. So leverage your own professional association, or if you don't have a formal one, getting a group of people together to form one and then begin establishing relationships with other organizations that have been around that can actually give you training and provide that, provide that partnership so that you don't have to start from block one. There are other countries that you can learn from and that you can actually partner with, people who would be willing to partner with mental health professionals in Bangladesh. You might also, one of the other things you could do with partnership is teaching skills for advocacy to help change public policy, because changing public policy may create funding for mental health agencies and support strategies. So it all begins, it all affects each other, right? And so like even a skill set of learning something called an elevator talk. And this is something that I've learned and I've actually used when I've engaged with my professional organization to go and lobby political leaders, elected representatives, where you go in with a 3 to 5 minute message about here's a very important mental health program we need to begin for men in our country, focus on this, that, and the other thing. And so there's skills that you can learn together as a group of professionals to learn how to then go to your own political officials, legislators, to develop policies and to develop funding initiatives to support mental health initiatives for Bangladesh boys and men. And then finally, thinking in terms of practical solutions and suggestions to enhance mental health support. So there are now therapy approaches that emphasize positive aspects of masculinity, positive male role models. So it's not about, throwing all of masculinity socialization out the window. It's about leaning into those aspects of male socialization that are very important to individual and family and community health and well-being. And then finally, some of the ways you can think about increasing accessibility and affordability is to think about community interventions. I was very honored a few years ago to work with a community-based organization, and we were able to apply for a local grant from the city of New York. And through that, we established a counseling center in this is a Latino and Latin American, predominantly Latin American neighborhood. So we were able to establish with a grant that established a bilingual community counseling center that then had afternoon support groups for boys and girls. We had male only, female only combined. Sometimes they focused on things as simple as how to get a job, but sometimes when you bring a group of young people to get together about how to get a job, you can actually expand that conversation to other things that might be more about mental health support and struggles young people may be dealing with. So those are just some of the thoughts and suggestions I wanted to share with you today. Thank you, and I'll turn this back over to Farzana. Thank you so much.
Thank you so much, Dr. Meville. Now I'll hand it over to Dr. Tasdeeq.
Okay, so do you want me to talk about the same scenario, or do you have any specific question to me?
So you can cover whichever topic you'd like within the mental health field, and we'll have a Q&A session at the end of the webinar.
Okay, thank you very much. I think as we are focusing on mental health, I definitely want to give Dr. Mary a quick thought about where we are in Bangladesh at the moment. So when Farzana was talking about the number of psychiatrists and psychologists, I think it's a very shocking number. She said 270. I think the correct number is 296 at the moment. A psychiatrist available in the country where the population number is 180 million. So it's you can easily understand the service they are providing. Our psychiatrists are trying their hard, but it's difficult when you have such a large population to provide service for them with such a low number of psychiatrists. It's difficult. At the same time, the number of psychiatric nurses, it is a very, I can say, like non-existent professional in Bangladesh. A very, very limited number of nurses are trained in mental health, and at the same time practicing psychologists. Farzana said 500. I think not all of them are clinical psychologists or those who are providing as practicing psychologists. So there are different variations. So I think practicing psychologist number is around 200, which stands for like one psychologist per million population. So overall, the population and the number of professionals are very, very limited. I'm sorry, I think there are some background noise.
If we could just keep the recordings muted. Sorry.
Yeah, it's fine. I think host can check like if any kind of voices they can. I don't know who is the host at the moment. It's fine. Okay, I'll just request everyone to mute themselves so that we can talk whatever we're talking about. Okay, so the situation is complicated because the budgetary allocation, if we go back to that situation, like the health budget, we have very limited amount of budget allocated for mental health, and the budget which is allocated for mental health is kind of centralized to the tertiary mental health hospitals. So we have two tertiary mental health hospitals. Listen, you can correct me if I'm wrong. The National Mental Health Institute, and another one is Pabna Hospital. And for mental health research and for mental health community-based intervention, when Mary was talking about community-based intervention, I was thinking like, do we have any sustainable solution? At least one example in Bangladesh where we can say like, this is, like Friendship Bench in Zimbabwe. That is a fascinating intervention. I think I have seen Friendship Bench in Malaysia. I have seen Friendship Bench in UK in Global Mental Health Conference. I know that in New York, there are Friendship Bench in some schools, because I think Dixon Chibanda told told me once, he's the inventor of friendship bench. I don't know if we have anything like that in Bangladesh, and when we can have something like a friendship bench. The main point here is we are talking about mental health, especially after COVID, which is a fascinating progress. But still, if we look into the scenario where we are still very, very behind. We're talking about, I think, a men mental health. I think that's what I was told, that men mental health should be somehow discussed today. I know when we talk about gender and mental health, we published a couple of papers. I think when Mary was talking about stigma, I'm just thinking about the recent paper we published on mental illness stigma in Bangladesh with Professor Armenia Colucci and me. I was the senior author for that paper. And in that particular paper, I think I'll share that link in our meeting, and also, if possible, maybe when the video will be published, you can add that in the comment box. So that particular paper, when we discussed about, I think it's the first one in Bangladesh to talk about mental illness stigma at a national level. Definitely female population had more stigma, which is quite, I think, likely with the national findings as well. If I go back to the National Mental Health Survey conducted by the government, I think we have some interesting finding here. I think we only had 3 National Mental Health Survey conducted, one in 1974, another one in 2005, another one in 2009. So interestingly, there was no pattern, like not 10 years, not 20 years. It's just like when they thought like we should have a mental health survey, they did that. So 1974, 2005, 2009, we don't know when will be the next one, 2019. If that is the case, like from now on, we'll go for a 10 years, interval for each of the surveys, that's fine. But I'm not sure if we have a plan like that. So the recent one, explicitly, they talked about male and female, because the first one, they haven't reported on men and women or any other genders. They just presented that 31.4% of the population in Bangladesh in 1974 are suffering from different types of mental illnesses, which I think was quite normal in that scenario, because it's just after the Liberation War. 1971, we had the Liberation War, so it's 1974. People might have that trauma, and kind of the post-war mental health impact, which is fine. In 2005, they presented on men and women only, and it's like for women, the number, if I'm not wrong, it was 19%. For men, it was 12.9%, so it's less than female. And overall prevalence of mental health disorder was 16.1. In 2019, which we are explicitly discussing at the moment, like in all our forums, the overall prevalence of mental health illnesses is 18.7%. For men, it's 12.5. For women, it's 18.8. I have had the honor to publish the first mental health country profile in Bangladesh. I was the lead author for that, and I'll share that link here. It's a 2-part series paper. In the first one, we discussed on the current state of mental health care in Bangladesh, in relation to the National Mental Health Survey. We discussed about the context for adult, children population, other groups, mental health care delivery. The second one, we discussed about the priority setting, research priority, advocacy priority, service development priority. So we did a literature search, and we kind of like presented this should be our priority if we want to reach somewhere. And at the same time, I had that opportunity to contribute as a consultant in developing the National Mental Health Strategic Plan 2020 to 2030, which has already been published. And our government, I'm very grateful that we have, in case of law, in case of policy, we have some solid documents where we can fight. We can say like we have this, and we are far ahead than our neighboring countries, that we have this policy strategies in front of us. So just going back to men mental health, and I was talking about the paper on stigma. One of my colleagues said like, yeah, like you talked about men mental health in many forums, but like all your papers are talking about women mental health. Like you are saying female are suffering more. So why still you are talking about men mental health? Are we presenting that men mental health prevalence is 0? No. So when we are saying 18% of the women are suffering, we're also saying 16% of the male or 12% of the male are suffering. So we need to have a balance. And we are kind of overlooking non-binary population. We are not talking about third genders. Gender is not about male and female. So we need to explicitly present. We need to capture their voices. We need to capture their suffering. I'm very happy that recently we published a large, we worked on a large data set with 𝐒𝐲 consortium. So it's the largest consortium during COVID we formed with 200 scientists from 40 countries, and we worked on impact of pandemic on mental health. We published a series of papers, and the last one we published this year, it's only on non-binary populations' mental health, how it got affected during pandemic, the suicidality and other stuff. So, but the interesting thing is, it is a very controversial topic. It's unfortunate that still in my country, it is controversial. And if we talk about it, we might get targeted, we might get threats and other stuff. So it is vitally important that as researchers, as scientists, we need to work on that. We should continue discuss on this, work on this, so that in evidence we have that. Definitely we have restrictions. We need to consider that sensitivity, and at the same time, we need to continue our work so that we don't restrict ourselves only talking about male and female and kind of presenting, okay, this is the case. No, it's not over. When getting back to men mental health, I think Mary already set the ground for that. In Bangladesh, one of the major barriers, what I found, and I think it's very clear to everyone, that the expectation from the society. We have a traditional gender role defined by the society where we expect that men should be strong, they should be self-reliant, men should not cry. And those expectations discourage men from seeking help for mental health issues because they think that they have that fear, like they have that fear of appearing weak or vulnerable, and that's why they do not want to seek for help. That is a big, and that is a like fantastic, example. We opened a social media forum, Men Speak Bangladesh, in 2021. I think Lisan heard about that, and it got popularity within a couple of weeks and months. But eventually, we observed that we are not getting enough responses. We opened it for men mental health issues, like where men will be kind of open up and talk about their issues, or we are thinking about creating some peer support group. But we failed. The program and the whole initiative kind of flopped because we are not getting enough responses. I was affiliated, I'm still affiliated to one of the organization. It's called Women Support Initiative Forum. One of my colleague, Dr. Kamrun, her fantastic, she's working amazing. That female group is working amazing because I don't know, I think the traditional gender role, and when Mary was talking about stigma, I was correlating that stigma is a significant factor for men when it comes to mental health. It is also preventing them to openly discuss their feeling, openly kind of seeking professional help. And we face that like immediately in clinical field as well. I think Lisan will talk about that as well. We experience that. It is there. It is still there, and kind of restricting men to talk about. And underreporting is another factor. Like men, they kind of less likely to report their mental health struggles, and in comparison to women. And one of the factor, as we do not have adequate or number of psychosocial interventions. So definitely, when we are discussing women mental health, in addition to reproductive health issues, we are not discussing enough on men mental health. And these issues are somehow going unrecognized and untreated in many parts of my country. So risk factors, I think men health, or like overall, the trait here in Bangladesh, like we have a lot of substance abuse cases. We published one paper in 2020. It's related to academic performance and drug abuse. And it was shocking to me because when we did those study in some of the very renowned universities, the prevalence of drug abusers and the prevalence of, it was so like heartbreaking for me as well as a researcher. Like, no, I don't want to say this, but it's my research finding, so we need to publish. And, in that paper, we published that, and it's kind of clearly talked about like men involvement because of the hostile culture, because of the peer pressure, also frustration and kinds of a chain reaction. So it is very much connected to mental health. When they are addicted to, even tobacco, that has an impact to mental health. Job-related stress, because traditionally job is kind of a characteristic feature for men in Bangladesh. Like a man should have a stable job. Even an woman with same caliber, if they don't have a job, it's not a concern for the society. But for a man, they should have a job and they should earn a standard amount of money to support their family. So this disproportionate like kind of structure of the society affecting men and contribute to the challenges they are facing. Also, I think one of the factor I thought I considered, like I don't know how to phrase it. It's like support network. We have very limited support network for men, where they don't know where to reach out, when and how they can get support. And that is important, because some of the cases, the trigger, like the stressors are inside the family. And when we are talking about domestic violence, it's not only the women who are victims of domestic violence. It can be the opposite. And when it is coming to a man, we are kind of tagging him with a different word, with some offensive statements. We are laughing and again kind of making him matter of kind of joke. And that's also kind of exacerbating like his feelings of kind of isolation and loneliness. I think another thing is always crying, the expressions or kind of the symptoms of mental health. We in Bangladesh, like we always have considered those symptoms as feminine, like when they are saying, I'm feeling lonely, I'm feeling like crying. These are feminine traits. As a man, why you are saying this? So these are kind of also creating barriers for them to recognize their symptoms and accessing appropriate support. Recently, like in my PhD, I'm working with deaf communities' mental health, and it's kind of fascinating to to understand their perspective. I'm saying this because it is absolutely different than the adult population, but there is a unique gender trait to this as well, because the deaf communities are, they are historically isolated, discriminated. And when it comes to mental health, they have very limited vocabulary to express their feeling. Because in Bangladesh, they are using certain, I think, communication sign languages, very limited sign language. So when we ask them, can you please tell us about your emotion? They kind of stumble. They said, emotion? What you're talking about? What is this word? So we had to pause our workshop. We had to stop it because they don't know the term emotion. They don't know the term depression. They know cry, they know sadness, they know fear, frustration, but they never heard the word PTSD. They never heard the word anxiety. So we had to pause the workshop and we had to get back to our psychologist, psychiatrist team, like what to do now? Because, like we are here to kind of getting a sense of their mental health struggles and they don't know the term to express this. So we had to create a whole set of new sign languages to express this. So we ended up, the task we did that time was creating a mental health sign language bank for deaf communities. We kind of taught them first, and then we asked them, now tell us what you are going through. So we are now publishing those resources one after another. I'm very excited to publish the papers because I think it's going to be a really useful like resources for talking about mental health of deaf communities, not only in Bangladesh, around the world. The reason I'm saying that, the kind of the pattern of gender, the suppression we identified in deaf communities, it's very interesting because in addition to female, I think the males are also suffering the same way. Like there was no significant gender variation like, the traditional society. The feeling, the suppression, the aggression was more or less similar. And the interesting part is when we asked them during the co-design workshops, what sort of content do you want? Do you want to learn about how to deal with depression or how to deal with anxiety? They said, no, we want to learn more about anger management. We want to know more about how we can deal with our loneliness. See, so this is very interesting. So the concerns we have for mental health, or kind of, like deal with our mental health struggles, is absolutely different from those communities, because the first thing they are facing is anger, kind of, frustration. And that is the basic, like the first concern for them to address. The understanding here is like, we cannot think of the same treatment for all people in the world or all people in the same country, where there might be gender variation, there might be, disability variation. People with spatial ability, people with spatial need have different needs, and we need to acknowledge that. And while designing intervention for them, we need to sit with them. When we are discussing with the deaf community, I'm not a sign language expert, so I can't do that. We hired sign language interpreters, like to discuss, so that they can tell us what they are going through. So we need to find our ways to kind of reach to them, so that we can incorporate their specific need into the system, and kind of tell the policymakers this is how we can support them. And another thing, I think, when Farzana was talking about, the gender aspect, it's very important to define this masculinity trait very, very clearly, very, very precisely. The cultural expectations and values which can influence masculinity, that difference of expression is very powerful. It is powerful in a sense, like that strong definition can change the, the characteristic of a person, of a child, because it's kind of the first day when they're like, the first day of the child, they're saying, oh, he's a boy, he will be a footballer, he'll be something. So we need to think very carefully what we are teaching to our kid. And I'm very afraid to talk about race here, because, like the book on race I read, it was actually written by Mary. That's what I was telling her off screen. One of the book, I think, Mary, you can remember, I think I read it in 2015 or 16. It's related to race in psychology. I forgot the whole name, but I can remember I think the name was maybe Handbook of Race and Ethnicity and Gender in Psychology, right? That is the book. Oh, yes. Yeah, that was my textbook. And I'm with the author at the moment. So that's the reason I'm saying, like, I'm very afraid to talk about that, because, like, yeah, another one. Great.
It's one on looking at race and ethnicity, in particular in connection to gender.
Yes.
So that other book.
That was one of the, reading material for me in global mental health. Yes. So racial identity, that is, I think, in Bangladesh as well, and many, many parts of the world, especially when men are from marginalized communities or, ethnic communities. I need to pause here and think, like, have we ever talked about ethnic mental health in Bangladesh? I don't know. We published 2 commentaries last year, Mary. So it's related to indigenous mental health. Me and one of my junior colleague is amazing. He's now doing PhD in US. So he's very much passionate about indigenous mental. So he pushed me. That's like, let's work on indigenous mental health. When we started working on that, like, we have nothing. Like, we always have talked about, like, when we talked about mental health in very limited scope, very limited, within a bubble. And when it comes to ethnicity, I don't think we have talked enough about the stereotyping they are facing, and they have unique challenges as well. And sometimes we tag them with hypermasculinity or hypomasculinity in some for the facial trait and other stuff. And at the same time, some criminal activities are related. Oh, these people are doing this. This also can have, impact on their mental health. And we are not discussing enough, especially in context of Bangladesh. And another thing which I identified as a researcher, like during COVID, we published a lot of papers, especially, after COVID, to see the impact of COVID and, on different populations. I remember, I was adamant, determined that we need to think about, student population, adult population, parents, everything. At one point, I was saying, like, okay, we are publishing a lot of papers, but are we touching down the base on capturing data from the poor population, data from the slum? Because, that time we are using online data collection method. We are within that bubble of, okay, we are just creating a Google form. We are sending that, we're getting ethical clearance. We're sending that to youth population. We're getting information. We're very happy. We're getting a lot of data. But where are the representation from the poor population? No. And that time it was not possible to go to the slum. And we actually have missed out a whole set of population who kind of represents the major set of population in my country. And like that is what we are doing as researchers. We have our limitations in budget, in our scope, and kind of resources. At the same time, we should have that passion, like somehow we need to capture the voices, the voices which are not being heard by the system or the policymakers. We need to think about them. We need to find a process so that we can include them in the whatever discussion we are doing. I don't know if youth policy forum will be kind of kind enough to invite someone from from that community to any of the discussion forum and ask from them like what they are looking for. They should not be polished in talking or whatever. They just need to kind of talk about what they are going through, their feeling, and that will make a more meaningful discussion with the policymakers. I'll just end by saying like as we are discussing about gender and mental health, media and popular culture is a critical and vitally important factor at the moment. I think body image or many I think media representation of masculinity, which can, I think it's powerful, but I say like reinforce stereotypical ideas, expectation, impose a lot of false expectation on men. And because the image of hypermasculinity in dramas, we Bangladeshis love to watch movies, and a lot of contents are available in social media. YouTube dramas are very, very popular in the country, and they are still kind of doing that, showing a wrong picture. And we need to definitely think a way to kind of monitor those. I remember one drama, I think everyone can remember that, when they kind of portrayed that autism is a scene by the parents. Remember, like that time there was a backlash. We all wrote in public forum tagging the director, and they had to withdraw the drama. And it was acted by the leading actor and actresses in the country. That was very unfortunate that they kind of agreed to act in those forums, and that created like, even if the drama is not available in any public domain at the moment, that time a lot of people believe that, okay, this is true. When like you are having a people like a kid with special need, maybe that is seen of your like that was like crazy. And I think it's a criminal offense when you are doing that in movies and dramas like that. And Bangladesh is like like they got influenced by those things. So we definitely do think about the unrealistic standards set by the media and popular culture, and we need to kind of think of regulating and monitoring it. We published a paper, I think in 2020. It's a very interesting one. I presented that in Harvard University with one of my colleagues, Enrica Christopher. She was working there at that time. So this paper was impact of social media on smoking initiation, and kind of like that is very interesting because like we in Bangladesh we haven't like had any paper before on related to that. And this one we used mixed method approach, and we have seen how social media like Facebook Reels, small videos, and kind of the picture, they talked about some artistic pictures by some senior brothers when they are showing the smoking in different beautiful patterns. They said, oh, I need to do that because that is the real masculinity, that is a real men they are using. They're doing this with their smoking picture. So we need to think about that. Like the kids are getting influenced, and we definitely need to find a way, because we have evidence. We have kind of a lot of discussion going on, but at the same time the discussions are kind of within a bubble. We need to get out of that, and we need to be in realistic in case of like addressing this kind of issues which is happening and influencing mental health. And we need to continue discuss on mental health wherever possible, and kind of get voice from underrepresented communities to get like the I think justice for them. I definitely want to use that word, justice, mental health justice for those communities. Thank you, Farzana.
Thank you so much, Dr. Hassan. That was so amazing to hear. Yeah, and I also do agree some of the research I've seen myself, it was talking about like the impact of media, and as well as the impact of like social support. I think in Bangladesh many times because of some of the things you mentioned that a lot of times because of stigma, there are people who don't support others while they know that another person is struggling with mental health issues. And we have seen in research over and over how social support is like a kind of buffer to someone's deteriorating mental health. So this was really amazing. Thank you so much. And now I'll pass it to Dr. Lisanul Hassan.
Hello, everyone. Am I audible? Okay, thank you for giving me the opportunity. And let me start by saying I'm really excited and I'm very glad that I have got this opportunity to listen to these excellent minds and got to learn a lot from you. So I know both of you, Dr. Mary and Dr. Fazli, both of you have shared some statistics and research about the mental health status and men's mental health in our country and like men's mental health in general. So let me start by sharing a personal experience actually. I have been working in several psychiatric settings for almost past 3 years, both government and private, inpatient and outpatient in various capacities. So one of my observation, let me be very clear, it's an observation, so it's not a research or statistics, that I have observed a very, I would say, disturbing trend in me in the psychiatric department OPD of a renowned government hospital that like whenever a madrasa student has to come to a psychiatry department OPD for any kind of psychiatric help, there is a pretty good number of them who have been subjected to various kinds of sexual violence. So it might sound shocking, and considering the cultural milieu of Bangladesh, it might sound blasphemous as well. So uh, when I actually observed this trend, I started to discuss this with my fellow colleagues and seniors as well. And then, like after having an informal conversation, what we have like tried to interpret from that actually it's not the problem of the specific religious institution, it's the pattern how these kind of institutions, the cohabitation institutions, are run, and where there is severe lack of monitoring and checking. So this kind of environment actually enables or the perpetrators to uh, commit this kind of horrendous crimes, and this kind of sexual violence has serious implications in the mental health of young men, adolescent men in our country. But when I have observed this trend, I decided to go online and try to find out whether there is any research on this specific topic. And unfortunately, there is, at least from whatever I have searched, there is none. So, as I have observed this for like past 3 years, and many of my colleagues have also observed that, yeah, uh, men or like young men who come from this kind of specific cohabitation structure, educational or religious institutions, many of them have, and those who are suffering from various kind of psychiatric difficulties, many of them have history of sexual violence. So, so I think this is not something new, but unfortunately, there is not enough research, and not only that, not many people actually are courageous enough or actually decide to talk about it openly in public forum. So, and this is one of the, I would say, sad and interesting fact about the mental health scenario of our country, and specifically men's mental health scenario of our country, that we don't talk about or we don't talk much, and we need to focus more on that. so that more and more researches can be done. And at the same time, those research will probably help us to find out ways to prevent and help those people who have been subject to this kind of sexual violence, specifically young male. And so this is one of the stories of myself treating young male patients who are subject to sexual violence that leading to various kinds of psychiatric disorders and difficulties. And for this webinar, I have decided to do some research and go online and see. Dr. Mary has already explained very eloquently about the psychological basis and different types of theories about how different mental illnesses are prevalent more in male gender and how some are more prevalent in female gender and what are the factors that are contributing to this kind of stuff. So substance abuse is definitely, as Dr. 𝐒𝐤𝐥𝐶 mentioned, and he has some wonderful research about that, is a really major concern in our country. And we have some researchers, but at the same time, we don't talk about substance abuse and how it affects our mental health and how it actually impacts overall the dynamics, societal dynamic and family dynamic at the same time. Because, some of the mental health difficulties of men are actually termed as men behaving like men. So suppose someone has difficulties managing anger and his probably anxiety or depression or adjustment difficulties are being expressed as severe anger issues, aggression towards others or something like that. And the society or family members or people around him or him actually don't look this kind of problematic behavior as a sign of mental illness because they don't have enough information about that. And so what they do is they actually, is everything okay? So what they do is actually they say like men acting like men, or like there are some specific lines such as boys being boys or something like that. So I think we need to address those issues, and if not addressed properly, the mental health gap will be increased day by day, and it will definitely burden our already straining healthcare service delivery system, where we have almost like very little psychiatrists and psychologists who are already suffering or who are already facing difficulties to treat those who are with clinical conditions. So for that matter, I think to address men's mental health, we need some really sustainable, easy, low cost, and preventative measures. That's really important because with the resources we have, with the manpowers we have, it's really not possible and feasible to address the mental health burden, specifically men's mental health. And where I think our public faces, specifically celebrities and others, they need to actually come up and help us to solve this issue and actually raise the voice of those who cannot due to societal stigma. And Dr. Mary and Dr. 𝐒𝐤𝐥𝐶 has mentioned some really interesting initiatives such as friendship bench or different kind of support groups. And I think this kind of initiatives are really low cost and they can go a long way in solving the overall mental health crisis in Bangladesh. So that's it from my side. And if you have any question, I would be happy to answer from my point of view. Thank you. And again, it's an honor to be here.
Thank you, Dr. Lisanul Hassan. We can definitely start the Q&A session. So some of the audience members wrote in the chat box. I'll just read it to all the speakers. What do you think is the largest age demographic for male patients in mental health setting?
Can I answer that?
Yeah, sure. Please go ahead.
Yeah, I think young adults and adults, like I would say it's 20 to 35 at most. Those who are the urban population, they are getting aware day by day, and they are seeking help. At least from whatever settings I've worked, these are the uh, demographics that I've observed.
Thank you so much. And do you think there is a disproportionate divide in help-seeking behavior in men versus female population in Bangladesh?
I think I can answer to that very quickly. Yes, the answer is yes. There is a disproportionate divide in help-seeking behavior. I think we already talked about that. A couple of our research, I think, explicitly describe the pattern that the help-seeking behavior is different. I think in case of male, in many settings, in rural settings, in urban settings, they are getting more support. They are receiving more support, and a female, they are not getting enough support and not also seeking for support. That is, the research is saying in real world, male and female both are not seeking for enough support. That is the reality. It is kind of, like a cultural, I think, restrictions. We already talked about that, and I think the answer is yes, yes, and yes.
Thank you. And another question is, we know that contrary to the trends we see in most of the world, the suicide rate for women in Bangladesh is higher than the suicide rate for men here. Do you have any idea on why the female suicide rate is higher? And additionally, it's good that this conversation focuses on the mental health of men, but wouldn't it be fair if we also sat down to discuss mental health issues of Bangladeshi women, especially given the fact that their suicide rates are higher in this part of the world?
I'll definitely invite Dr. Mary to discuss on that. I think it's not about Bangladesh; it's a global, I think, global kind of phenomena. So please, Dr. Mary, if you can answer to that.
Well, actually, I was not aware of this situation, and I do find it quite concerning. I earlier had talked about the gender paradox, that at least in the United States, more girls and women think about and attempt suicide, but more men end up completing, so that the higher rate is for men. And so, just a couple of questions to query this is there a difference in methodology? I mean, are Bangladeshi women choosing much more harmful methods? Is that a reason why, sort of the way the men in the United States might? Or is it that I'm just curious about the rates for men as well. And I would want to query a little bit more each of the suicide. But honestly, I think that would be a very concerning issue to look at. And yes, I would presume Farsana and her colleagues will at some point organize a panel for mental health issues for women. Absolutely. I think that is also as important to focus on. Thank you.
Absolutely. Dr. Mary, I'll just clarify here that in Bangladesh, we do not have a suicide surveillance system. That is a major kind of loophole, as the reason for underreporting or over-reporting, or, we mostly depend on newspaper source and some police reports for suicide reporting. Even in literatures, you'll see citation from a newspaper or citation from a police report. So we do not have I think we are discussing on that. Like, we do need a suicide prevention strategy like this, as we have a lot of advancement in policy area in case of mental health. We are behind in suicide prevention strategy, which we do need. Also, we need a digital mental health strategy, I think, because it is very much relevant to suicide and other. Specifically, I think Listen can contribute here as well. It's related to I think not common. I think it's severe mental health conditions. I know, like, it's a very interesting trait. I don't know if you're aware about this or not. In Bangladesh, we have some TV shows where the doctors can sit and kind of, the patients can call, say, oh, I'm having this problem. Can you please treat me? It's very interesting. We are seeing this since like childhood. It's a violation of privacy. It's violation of confidentiality, ethics, morality. everything in all ground. This is wrong. Interestingly, for when we are talking about digital technologies for mental health, telemedicine, telepsychiatry, maybe we can support to a certain level for severe conditions like psychosis, which can turn to suicide, or severe depression can have consequences like suicidal attempt or suicide. We are trying to support without having any policy, I think, limitations or like any guideline, which is very important, like how far we can go, how and when we can engage the family members or other, like legal authorities to inform that this can happen. So I think this too, I think as we are talking to a public forum at the moment, I'll definitely request our concerning authorities that we do need a suicide prevention strategy and definitely digital mental health guideline, like a clear-cut policy framework, how and where and to what extent it can be done. Yeah.
And also paying attention to some of the financial and other pressures. There are multiple organizations around the world that have already done a lot of excellent work. So it's you can also look at that, and then it's not just a matter of applying it without questioning it. You have to look at it and see how then to apply it with one's own community, racial ethnic community. The other thing I wanted to say, I really appreciate what you shared, Dr. Tasdik, is what Lisanal had mentioned in his comments, which is, in what ways do mental health concerns of men get masked and don't get counted? And so I might suggest to look at sort of the criminal issues of violence, especially violence toward women, violence towards other, because I would argue that's a reflection of mental health as well. And so if you have this bifurcated or divided situation of women attempting and committing suicide more, but is it men who are engaging in more violence towards other people? I think that's something also to look in context, to look globally at all of that, so that it's actually, how is it that men are expressing their concerns? Is it about expressing it towards other rather than oneself? That's also a reflection of mental health concerns.
Thank you so much, Dr. Mavil and Dr. Tasdik. One of the other questions is, do you think mental health setting in Bangladesh have enough knowledge in identifying differences of symptoms caused by gender variation?
Wow, it's a very interesting one because like I think Lisan is here, so he can respond to that. He's treating in the tertiary, I think #1 tertiary hospital in Bangladesh at the moment, and is a very young physician psychiatrist. The thing is, definitely, if we think about the settings, suppose like we are talking about a tertiary hospital, a GP or a psychiatrist, whoever is present there, they do have that knowledge to identify differentiating symptoms between different genders. It's possible. If we think about the community settings where a community healthcare provider, CHCP, in a community clinic, I argue that they might not have that capacity. In case of district hospitals where we do have very limited number of doctors available, we can't expect like a psychiatrist in that setting. Definitely there might be an issue. I think I'll request Lisan to share some of his experiences. I talked to him before on this, so maybe Lisan can contribute here.
I agree with Dr. Tasdik Hassan. Actually, yeah, in tertiary care facilities, psychiatrists and non-specialist doctors who are also working in Department of Psychiatry in various capacities, I think most of them have some kind of background knowledge to differentiate and actually figure out those differences and treat accordingly. But I'm not so sure about doctors and other healthcare providers working in district and upazila level and other levels, or in different private setups. Because as Dr. Tasbih rightly mentioned, we have very little resources, and they're they need to cater to a lot of patients. And so I think, and also we don't have, I think, enough training during our undergrad medical school days about like psychiatry or mental health. I'm not so sure about like primary and secondary settings. But I hope at least tertiary care physicians have that kind of expertise to deal with mental health conditions from a gender lens.
Yeah, so I'll again talk on this because it's fascinating to think about this at the moment. As a doctor, we are like being taught about a mental health condition. It's not about the gender lens. It's about a case of a depression where we know, these are the symptoms and we know how to classify or identify mild, moderate, severe depression, and we have treatment modalities to treat a patient. And when we are discussing about the gender variation, so it's not only about, what are the prevalences of a particular disorder among male or female. It's about that's the difference in expression, difference in perception of a particular symptom and the way they are presenting to a hospital or a clinical setting. I think that is very important. It's a sensitive, I think, critical thinking, and for a clinician and also a healthcare provider. I do not kind of restrict itself to psychiatrists or psychologists only. It's about GPs and other healthcare professionals because, in Bangladesh, as we only have 300 psychiatrists, we can't expect that 180 million people can get support from them. So, of course, other medical doctors, see, like I studied global mental health, which is a social science oriented, social science focused degree, and kind of doing a lot of mental health research, digital mental health. So I don't have a psychiatry training. And listen, you are a emerging psychiatrist. But in our medical school, when I was studying MBBS, we had a particular training on psychiatry where we are being taught about some diseases, like basic diseases, and which allow us to treat a patient of psychiatry. I think which is true for all of the GPs around the world. Like they can treat up to a certain level and then they can refer to an expert or, the specialist care. My point here is it is critically important to think with a gender lens so that we can provide appropriate support, considering the differences in presentation, expression, and also if we need to change the treatment modality. Dr. Mary, I think we do need your expert opinion here because it's definitely a fascinating start of a discussion. Yeah.
I think both of you have talked about it beautifully in terms of the context for Bangladesh. I actually don't have anything more to add. I think both of you have reflected very thoughtfully on the particular situation in Bangladesh.
Yeah, so I was thinking, like, if you can tell us about if in US, in the psychiatrist or psychologist, do they have any specific course or training they learn to deal with, gender specific expressions or need of mental health that we can propose to the system? Yeah.
Well, Farsana is hopefully a beneficiary of the kind of training we now provide in the United States. And that is you can take courses, actually formal classes, where you review the empirical evidence, you talk about types of interventions that are cued towards looking at gender. And I think you're right, Dr. Tazdik. It's never about any one particular variable, in this case, gender, but a particular variable can help you really understand much better nuances that might be really driving a situation. And I do really wonder about, especially with the suicide rates in Bangladesh, and that they are so gender divided, and that they are different than certainly what I've seen in other parts of the world. I do think there are some gender variables here. And as I noted earlier, it would be important to look at the relationships of women and men, particularly in households, in families, as to what happens in the family setting that may be leading, I don't know if it's young girls who are committing suicide. Is it middle-aged women? Is it older women? To better understand what are some of the features of people making that very difficult choice to end their lives, to see what commonalities come from. But yes, I do agree, Dr. Tazdik, that having formal training that specifically identifies gender and the kind of research, because there is now a lot of evidence, at least a half century of evidence that would be helpful to mental health practitioners in Bangladesh to better understand how gender has been found around the world to impact many aspects of mental health. And we have found it for education, we've found it for career, we found it for relationships, we found it for childhood, for family. I mean, we have found there's evidence of the impact of gender for all aspects of life so far. And, I'm saying it's been found a lot in the United States and Europe. There's been some of the areas, and that is, I think, potentially a very fruitful area of both research and then training, based on what we find in our research for psychiatrists, for counselors, for mental health professionals of all kinds. And do you know that we now even have training for just like officials or staff members, say at a community agency, who may not even be trained as a psychologist, but they're trained to identify whether somebody coming up to their desk might be at risk and to make a proper referral to where they can. So there is lots of information out there that I think would be worth the time for a trainee in any variety of health sciences to learn about gender.
Fantastic. I think we can think of applying gender lens in mental health education in Bangladesh can be another webinar topic for Youth Policy Forum. And listen, maybe you can carry it to the Psychiatric Association of Bangladesh. Yes.
Thank you so much. And I wanted to echo to what Dr. Mavil said. Currently in my program, well, the program I was in, we had a course that was offered now, and I think that all goes to the fact that the institution, like universities, are understanding the need for mental health professionals to understand the importance of the context with which every client, every patient comes with. So when the class was multicultural psychopathology, and it's a very new course which was talking about the clinicians looking at each different person and doing research into the cultural background, no matter where they come from. Since New York is a very diverse place, it is a great place to start and have a lot of case studies. So that just made me think of that class, because just like that class, we also have a lot of like employee onboarding. So whenever we start a new job, we have employee onboarding that requires certain mandated course. So I just wonder if in the next few years, Bangladesh will have those trainings available for mental health professionals, who will include like the various different terms that mental health is explained as. So just to give a small example, in African population, they have seen West African population, I believe, that when someone experiences depression, they said, my head is hurting. They don't explain it the term we would refer it as. So to learn the variations, and also to consider the subcultures within Bengali cultures that we have. It's not just a gender-based issue. We have multiple different states like Sylhet, Chittagong, like all those places. And I'm not too sure about, I'm not too familiar with each of the different variances within the states, but I'm sure there are cultural differences in the way people speak about their symptoms. So to notice those as well as gender differences would potentially be more beneficial. And yeah, so I wanted to thank everyone. We're almost at time. It was such a pleasure to hear you all. And if it's okay with you all, would it be if everyone can turn their cameras, or if you're not comfortable, you don't have to. I wanted to take a picture of everyone just as a memory. And I think we can stop the recording.